So without further ado, I would now want to kick off the presentations, and it is my honor and pleasure to first introduce Professor Peter Lüdike from the University of Essen, who will discuss the PASCAL platform and how to deal with functional MR. Peter, welcome.
Yeah, good evening, everybody, and thank you very much for this kind introduction and this spectacular video. It's an honor to participate in this webinar. So these are my conflicts of interest, and these are the highlights I want to address in the next few minutes. It's nearly 2 years ago that the PASCAL platform entered the European market and added 4 novel key mechanisms to the well-known principle of edge-to-edge repair. And these are the central spacer, which somehow renamed this technology because most authors call it the edge-to-spacer technology. This was the opportunity to independent leaflet grasping through the independent clasping mechanism, the smooth nitinol design, and the ability or the opportunity to completely elongate this device to create a very flat design. On top of these mechanical innovations, a second size of this novel device was introduced last year in the pandemic year 2020 and addresses special anatomical needs by this different design and this different size. This device is called the PASCAL ACE implant, and you see here the direct comparison with the PASCAL 10 platform. It has a narrower profile, but I don't want to go into detail to this because Philip will talk about this later on. What is exciting to see from a user perspective is the fact that not even 2 years after the first commercial application in Europe of this device, there are frequent innovations of this young technique coming in, and the most recent or the next upcoming innovation is a redesigned stabilizer system that consists of only one table that provides more stability and makes the maneuvering even easier. The table is designed to stabilize this delivery system you can see here in this slide, which consists of 3 independent catheters which allow for maneuvering in 3 independent planes, and the whole system is quite flexible and allows you even extreme angulations during the procedure. From my personal perspective, I really like that you can guide and steer the whole system like we are used to from coronary wires, so it's very intuitive. Well, the most prominent innovation of this device obviously is the spacer, which you can see is here placed in this illustration from a case we treated some weeks ago, where the spacer is placed between the leaflets, but the spacer has not only the function to fill the gap between the leaflets, it reduces the stress that we put on the leaflets and guarantees an even increased residual open valve orifice area, what is nicely illustrated in this digital animation you can see on the right. This is a digital animation that compares an edge-to-edge repair when you use a device without a spacer. This is the upper image, and with a spacer containing device. This is the lower image. And what you can see that edge-to-edge repair with a spacer containing device is expected to result in a residual or in an increased residual open orifice area during the relaxation of the heart. Another important detail another important detail of the spacer device is the alignment of the retention features, which is parallel to the anatomic direction of the collagen fibers of the mitral valve and allow for multiple grasping attempts. And without injuring the tissue in the area of grasping, what we use in the meantime quite frequently to optimize our results for multiple grasping attempts, to optimize the reduction of MR. In combination with the opportunity for independent grasping, this could be a real comfortable combination in complex anatomies, as displayed in this echo loop that was recorded during a case where we treated a patient with a congenitally corrected transposition of the great arteries with an extremely angled anatomy, and it was not possible to get a normal steering as we know this from normal cases. And you see here how we were able to grasp the first leaflet before we swung over later on to get the second one. So the most important, from my very personal perspective point of view, or innovation of this technology, is the combination of the very smooth design and the opportunity to elongate the whole device once you entangle with anatomical structures. You see here in this slide the wholly elongated device, that what is a nearly completely flat profile, and this fluoro you see in the next image was a recent case where we treated a very medial pathology in a young patient, and you can see the bouncing, the back bouncing of the device when we elongate the device. We entangled in this situation with the cordia in this very medial pathology, and it was quite easy just to elongate to escape from this quite dangerous or impossible to maneuver situation. The elongation feature comes along with a very smooth closing mechanism of the clasp with passive constant force that does not allow you to overcome relevant mechanical resistance from the tissue. And you can nicely see in the next image this ongoing movement of the device arms even after closing the device, what is an impressive illustration of the effects of the nidinal material. And basically, this is the point I want to make in this talk. When we talk about TMVR and mitral valve, then we talk about a very filigree structure that divides the high from the low pressure system in our body. And we talk about a lot of power that is behind this filigree structure. And while some interventionalists first feel uncomfortable, I don't know if uncomfortable is the correct term, but the very flexible design is quite uncommon for us who are used to a very stiff and mechanical device. And I really learned to appreciate the flexible design, since it saves you from overcoming anatomical resistances of this filigree structure of the mitral valve. And my simple bottom line is that the PASCAL device saves you from placing the device where it should not be. And this is a very important message from a user perspective. So these are the insights into the novelties of this technology. And when we take a short look into the few available prospective data from clinical trials, this was at first the single-arm multi-center prospective clasp study, then we can see that there is an impressive longevity of the obtained result, even beyond 6 months and 1 year. And it's important to emphasize that the upcoming and currently ongoing trials will finally answer the question like non-inferiority to the MitraClip system or efficacy in treating tricuspid insufficiency in comparison to best medical treatment. When we look into the real world, then there is this big Edwards Lifesciences data bank that collects all proctored cases worldwide. And there are 2,000 cases available in this database. And with all the limitation that comes along with an industrial managed data set, this illustration shows nicely that it takes just 15 to 25 cases to really master the system to obtain excellent results in reducing the MR to a level of 0 or 1+, even in mixed pathologies where we know that these are very challenging cases. While this is a quite obviously suggestive illustration, we really can confirm these data and this trend in our own cohort at the West German Heart and Vascular Center. And you see here an analysis from the last year where we put together the first cases treated at our center. And we confirm the safety profile and the efficacy profile seen in the CLASP study. And what we are currently prospectively evaluating is if there is any anatomical limitation that make an application of the PASCAL device impossible, and until now there was not a single case where we needed to apply a different edge-to-edge technique due to anatomical circumstances, just due to patient's explicit request. So it was an exciting journey during the last 2 years, and it will be interesting to see how the impressive outcome data of the CLASP study will impact our daily TMTT habits, and I hope I could give you a concise but comprehensive overview over this technique. Thank you very much for your patience.
Peter, excellent presentation. I was intrigued with the introduction of PASCAL last year in my center, and I was specifically looking forward to the independent grasping. And from time to time we are using it. In your experience, how often do you need the independent grasping?
Well, to be honest, it was a biphasic learning curve. At the very beginning, I didn't use this very frequently, and I was not sure if this is a real game changer and if we really need this. After gaining a little bit of experience with the new system and gaining confidence in the fact that you can refine your result without losing the leaflet. This is something what we are all afraid of when you have a complicated case, that you open again and then you lose the leaflet. And when you realize that the constant force on the clasp or the retention features will guarantee you that the leaflet will stay in place, then we started again to really optimize our results. And this is something what I just can recommend. Take your time, because it's possible with this device, without losing a good result, to make it even better.
I would like to ask a question to Stefan van Baardeleben from Mainz. He has a massive experience with all kinds of catheter-based therapies, and so this other particular feature of this technology, of PASCAL technology, is of course the central spacer, and it aims to reduce the stress on the leaflets. In your opinion, would that reduce indeed the stress on the leaflets, and would that reduce the incidence of single leaflet dehiscence, for instance?
I think there are two components, not only the central spacer, but also the nitinol material of the device, that both enable actually to reduce stress on the leaflet. The spacer actually prevents the direct coaptation of the leaflet, but it's more an edge to spacer to edge procedure. On the other hand, the nitinol is capable to reopen under stress. So we see this very often in the immediate results, that when the patient still is partially decompensated or gets a hytropic decompensation afterwards, that the device is able to open a little bit and to exert some suspension force back to the original position again. And I think these two components, spacer plus the nitinol material, is very interesting. Also, of course, the frictional element, Peter has shown this nicely, with the collagen structure of the leaflet, also enables not to bite too much into the leaflet. So I think these three components actually open new perspectives on less leaflet stress, not to pull so much on the annulus, and especially in patients that have very old frail leaflets or have nodular calcification. This can be very interesting. I agree with him that direct clasping is the preferred method, because you don't get an angular misshape, and that the post-optimization, which is often only 3 millimeters, can make a huge difference in the result of the procedure. So I would see these factors as being preventive for leaflet rupture, and also causes for the high MR1 plus success, which is, as Peter has shown, between 80 and 90%. And that's something we should aim for in the future.
Yeah, so Stefan, basically what you're saying is that if you can, you should do simultaneous grasping and then optimize after. Is that what you're saying?
That's our strategy, because the so-called Tarzan maneuver to swing over very often has the disadvantage that you can slightly rotate or turn, and you can fold or mistract the leaflet, one of the leaflets, into a certain direction. So our strategy in most of the cases is to attempt a simultaneous clasp and then to reopen the side that you consider to be more frail, and you can look at both sides, of course, but then to introduce and to move over to the frailer leaflet a little bit by 2-3 millimeters and get more leaflet into the edge-to-edge system, into the tier, in order to optimize the result. Especially with the spacer, it's very important that we get the tip of the leaflet below the spacer. So the spacer is above, both leaflets should enter very deep into the device. And if we do this, ventricular pressure will press against the spacer. So a good insertion is a prerequisite for a good result with the PASCAL technique.